is Alex Bornstein. I'm the Chief Operations Officer for Foodbank. And I'm here to welcome Jessica Hager for her session. The session is Illuminating Intersections, Food Insecurity, Nutrition, and Health. So if you're in the wrong workshop, please feel free to go to your intended workshop now, although we hope you stay for this one. At the end of the workshop, please complete the evaluation on the green paper on your seat. You can give it to Connie, who's right there, at the end of the workshop. And just a little bit about Jessica. For those of you that did not attend Jessica's first workshop, she is the External Engagement Manager of Community Health and Nutrition at Feeding America. That's a great title. Yeah, that's right.
That's a short version.
Is it? Works to increase awareness and collaboration around the intersection of food, insecurity, nutrition, and health. Manages healthyfoodbankhub.org, a public site for nutrition, health, and hunger relief professionals. She has a BA in Communication Studies from Southwestern University and an MA in Social Service Administration from the University of Chicago. And it is with great pleasure that I hand the mic over to Jessica.
Great. I'm going to be doing a lot of yo-yoing as I click through here today. So, as Alex said, I'm with Feeding America. So if you're not familiar with us, we are based in Chicago, and we're a national organization that works with the food banks across the United States. So Vermont Food Bank, of course, being one of our wonderful members. And those 200 food banks collectively work with over 60,000 food shelves or food pantries across the U.S. So a big applause to you all, because collectively we serve 46.5 million individuals. And so that is a huge amount of folks in the U.S. And really gets at the large majority of individuals who are experiencing food insecurity in our country. So thank you for having me here today. It has been a pleasure being at the conference and hearing your other keynotes and being part of the session. So if you have questions along the way throughout the session, feel free to raise your hand. Sometimes I find it's easier to address the questions in the moment. So, and leave some time at the end. So I shared a little bit about I'm seeing it. So some of our learning objectives for today's session is to help us understand the connection between food insecurity, nutrition, and health. Some of this, if you were in the first session, I see a few familiar faces. You'll see some overlap, but I'm really going to be able to dig down deeper into the local Vermont numbers for this. Also sharing some insights from Feeding America's most recent research that's called Hunger in America. Can I get a show of hands for those who participated in the Hunger in America study? So okay, great. So I'll share a little bit about that study going forward. We're also going to explore why traditional nutrition education strategies are always great. They're evidence-based a lot of times, and so being able to use those in the food shelf setting. But what are some adaptations that we can utilize to help get at the specific needs and challenges of individuals who are experiencing food insecurity? And many of you may have your own stories that you're able to share with us today. And then also highlight strategies and resources available on healthyfoodbankhub.org. I'm not opposed if you want to pull out your smartphone and check it out. We have it mobile optimized, and so feel free to do that. So I always like to begin with the definition of food insecurity. And so this is according to the USDA. We know that, and sorry, holler if you can't see the slides. But food insecurity is the lack of access to enough food for a healthy, active life. And so it's not just getting food into our bellies, but the proper foods into our bellies so that we can lead that healthy, active life. And according to the Academy of Nutrition and Dietetics, we know that food insecurity is linked to 5 items, which I'd like for you all to share with me today. So if you have a white piece of paper on the back of your chair, you can rip that off, or it might be in front of where you're seated. I think that's you.
I figured I was the one.
You can pass it to your neighbor if you don't want to. So I see you have a white piece of paper on yours too. So we'll start with number 1. So if you would just stand up and read the statement.
You're number 1.
If you just read the statement that's on there. So again,
I do not want to be number 1.
Great. So food insecurity is linked, so we'll have number 1 stand up and share what's on your card.
Food insecurity is linked to poor nutrition.
Great, thanks. You have number 2, we'll go on to session.
Food insecurity is linked to poor health. Food insecurity is linked to increased risk for the development of chronic diseases.
Food insecurity is linked to impaired psychological and cognitive function.
And food insecurity is linked to substandard academic achievement.
Great, thank you all. So again, we see that the Academy of Nutrition Dietetics and of course other researchers and physicians are telling us food insecurity is linked to many of these items, all of these items, and many other factors. And so taking that into account as we think about the great work that you're all doing when you're serving individuals, you're actually impacting many of these other variables at play. And particularly, I know that's the case as we as a collective network have been working to provide more fresh fruits and vegetables or healthful products. And so that really gets at particularly these first three items. And when looking at the intersection of food insecurity and nutrition and health, it's really important to look at the risk factors. And so we know that people at risk of food insecurity are also often at the highest risk for obesity and diet-related diseases. And those common risk factors for each are very much the same. There's low income and poverty, poor nutrition, marital status, race and ethnicity, limited access and affordability, which we're all directly addressing, low cost of energy-dense food, and cycles of food deprivation and overconsumption. So kind of that yo-yo diet that someone may be experiencing. And so we'll talk a lot about that cycle today. And so I just like to start with the numbers, and I'll just stand up here and I'll actually sit if you don't mind me doing so as I click through. So we'll start with the numbers. So food insecurity, in the United States, 16% of the population is food insecure. And this really is differentiated between different demographic groups. So we see this with race, being that just over a quarter and under a quarter for Blacks and Hispanics are experiencing food insecurity nationally, and just about 11% of whites. We also know that about 20% of households with children are experiencing food insecurity. And we see this reflected in a lot of the free meal programs that are going on at schools. And looking at obesity, we know that 35% of individuals in the United States are living with obesity. Again, this is a disparity in the demographics, particularly with race. 47.8 with Blacks, 42.2 with Hispanics, and 32.6 with whites. And I think it's really important to note, as we think about solutions to these, that children and teens who are obese often continue to be obese as adults. So when we're thinking about strategies to address these, really starting as early as possible is the goal. And I'll show here, you can see the Vermont numbers. So I'll first note that Vermont is lower than the national averages, which is really wonderful. And that speaks to the great work that you and your partners are doing in the community, that residents themselves are doing for their own lives. And so food insecurity rate here, as you all know, is 13.6. And these are the 2013 numbers, I should note. And for adult obesity, the rate is 24.7. So again, lower than the national averages, but still high. And we also know that the relationship between food insecurity and obesity is a really complex one. And so it's not fully understood, but we know that it's really rooted in poverty, and that's the common denominator. And so we associate hunger, as you can see here, with eating too little, and obesity with eating too much. But in the United States, both can result from lack of resources. And so here you can see that as income goes down, obesity goes up, and this is particularly the case for women, which Cornell did a very interesting study, which I'll share on the next slide, as to why this may be particularly the case for women. And some common risk factors between food insecurity and obesity is, understandably, elevated stress and anxiety and that constant state of being in that place of being, and then also poor nutrition. And in both cases, if you look at the top bullet point, it comes back to our body physiologically storing fat. And so when we're stressed, cortisol gets released and we're storing that fat in our bodies. And so it takes a long time, even if it's just like adrenaline that you're feeling, for that to get out of your body. Additionally, we know once having poor nutrition, we're consuming food items that don't necessarily have the most healthful ingredients for our bodies. And so therefore, again, we're holding on to fat. So we like to look at, diet-related disease. This impacts hypertension, diabetes, etc. And so today I'm going to be looking a little bit at diabetes specifically. And in the latest Hunger in America study, we had some great new questions that were added to help us understand what does diabetes and hypertension look like for the communities that we're specifically serving. So I'll get to those. And so to begin, we know that individuals who are food insecure have an increased risk of diabetes. And those, if you know, there's the USDA determines you can be food insecure or you can be very low food insecurity. So there's two different determinations. And so those actually who are very low food insecure are 2 times as likely to have diabetes. And so additionally, there's additional challenges for diabetes management, lower diabetes self-efficacy, higher rates of diabetes distress, and more frequent ER visits due to hypoglycemia. And hypoglycemia is, I always remember it this way, it's the O for low, so low blood sugar, hyperglycemia is high. And so that back and forth is really detrimental to one's body. And so here's the cycle. And so Hilary Seligman, she's at UC San Francisco, the Center for Vulnerable Populations. We work a lot with her on some diabetes research at Feeding America with local food banks. She's a great advocate, does a lot of work with food pantries in the California area. And she created this cycle. And so it was published in the New England Journal of Medicine. And this was her way of helping just the general lay individual, myself certainly included. This was really great to understand that cycle of someone who is food insecure but living with a diet-related disease, again, specific to diabetes. And so here's how she explained it. That one, an individual is in constant state of stress, more likely. So when one's food insecure, again, that's lack of access to enough food for a healthy, active lifestyle. And when one experiences that, we go through that cycle of food adequacy and inadequacy. Poor self-management capacity for diabetes, and you have competing demands. And so when that occurs, it's difficult to control diabetes. So you have poor diabetes control, then increased complications. And when one has increased complications, what do we do for any of our illnesses? We go to the ER, we go to the local clinic. That costs money. And then you're having to go back to your household budget and look at I'm putting more money for healthcare costs, less available for food, or less available for education, transportation, utilities, housing, etc. And so that cycle just continues to go forward. And I imagine it continuing, but then kind of a spiral downward. It's much more difficult when we're looking to stabilize our lives if we're food insecure and living with a diet-related disease. Sorry about that. And so just another visual for this, again, from a physiological perspective, looking at someone choosing from unhealthy and expensive foods, which we've learned from the Hunger in America study. Again, I want to be clear, it's not a choice of not knowing that these are unhealthy foods, but it's more of competing demands. And eating more to avoid food waste when food is available. And then having to skip meals or snacks. And so having to jump back and forth for your body to deal with that is extremely difficult. Great, so the Hunger in America study is, again, a study we do every 4 years, and it could not be done without those at food shelves and food pantries, and as well as for the individuals that are coming to the food pantries to volunteer to take the surveys as they do. And so just want to, again, thank those who have participated. It's a huge, heavy lift to get this done every 4 years. And again, it's the largest, most comprehensive study of its kind ever done in the United States. And one of the great things about this is that, yes, we have national data that tells us X amount of people have diabetes, X amount of people are obese, or making these trade-offs and coping mechanisms, but now we can really understand, for those that we're interacting with every day, our neighbors and community members, these are the challenges that they've shared with us, the experiences they've shared with us, their health implications that they're living with. And so what we know is that from Hunger in America is that 63%, so well over half of individuals of households, report planning to get food at a program on a regular basis. And 37% of households report waiting to come. So this really speaks to, and for those who were in the earlier session, this change from it being the emergency food system to the Charitable Food Network being one that individuals are, as they're looking at their household budget for the month, they're really planning to come to the food shelves. And this is something that, maybe a raise of hands for those who've seen this in your own food shelf, individuals coming on a regular basis. And, in one way, this is great. Families are really strategizing and making the best of what they have available to know. I know the food shelf is a reliable source. they clearly see you all as a great value in their community, and so they're building you all into their monthly budget. At the same time, though, it speaks to that stability and that progress to getting back on their feet is really difficult and complex. And that being said, we play a much larger role in one's ongoing nutrition if they're coming on a monthly basis. And what we know is that nationally, I'll begin and then I'll talk about the Vermont numbers. Nationally, 58% of households, again served by the food pantries in the U.S., have a member with high blood pressure. And 33%, or a third of households, have a member with diabetes. And what we know is that when one individual in a household is living with a diet-related disease, it is by no means uncommon for an additional individual in that family to have diet-related disease. And so we can consider these numbers a little more on the conservative side as we look at this. And we also know that 47% of clients responded that they're in fair or poor health. So these are individuals, we didn't take a test to determine what poor or fair health is, but these are individuals self-reporting and saying, you know what, this is how I see myself and my health condition. So for Vermont, we have 46% living with high blood pressure, and 23% have a member with diabetes. And so when one lives in food insecurity and with other competing demands, we know that tough choices are made. So, every month in our household, we sit down, we plan our budget out, and we're pretty kind of regimented in how we go about doing things. But at the end, we always have some disposable income, which is really a luxury. And so a lot of families don't have that. And when they're really looking at their basic needs, they're having to decide, do I pay for housing this month? Do I pay for food? Do I pay some of my rent check? Do I pay for food? And so we see when it comes to health, that 66% have had to choose between paying for medicine and paying for food. And again, these are across the board: utilities, transportation, and housing. And in Vermont, we know that this number is 56%. So again, lower than the national average, but still over half of those that you're serving are having to make this decision. And I will note that for those individuals that are living with a diet-related disease, we know that disproportionately, not only are they having to make that decision between medicine and food, but we also know that they have unpaid medical bills on top of this. So again, it goes back to that cycle. And coping strategies. So when you've set your budget and kind of you've made your line items there, we also know that individuals are looking, how can I kind of help meet the needs that I'm going through? And so this gets back to 79% of individuals are purchasing inexpensive and unhealthy food. And so that could be that they've run out of SNAP dollars, or they have a little bit left for that month, and so they're just getting as much as they can to hopefully fill their stomachs and their children's stomachs throughout the month. And so here in Vermont, just a little bit lower, from 79 to 72%. And this goes back to, yes, individuals are making a choice to buy the less expensive and unhealthy foods, but that's not what they're wanting to do. So we know from this survey, Hunger in America, that clients most frequently identify fresh fruits and vegetables, dairy, and protein as their top priorities when they're coming to the food shelves. These are the top things that they're looking for their family's diet. And we also know that this is very much in line with what you are looking for. Over 2/3 of agencies indicate that it's very important to them that their agency distribute and serve healthier foods. And certainly costs being a barrier to that. So I wanted to stop there. That's a lot of information essentially that I'm just throwing out. So I'd love to stop and answer any questions that you all may have. Okay, great. For these statistics that I shared, are those kind of seeming in line with what you've all experienced in your work? Some nods, yes. Okay, yeah.
I would just say that certainly I'm with a relatively small food shop in a rural area, and I would say that the levels of heart disease and diabetes are even higher with my client group than the statistics would indicate. In fact, I think we have almost every person, every client that uses our service has medical issues that are diet related.
Yeah.
Which makes the job that we do even more difficult.
Absolutely. Are there collaborations that you all are in working works with medical, and not that there has to be, but that's kind of jumping to our next part, so maybe of interest, but I don't know if you all were doing any work in that space.
Too small.
Yeah, well, that's where it starts, right? So, yeah, absolutely. Any other questions? All right. So, talking about models of collaboration. So, you actually, I could have planted you as the next talking point because it really, and sorry, I will read this because I realize you probably can't see that. But, you know, when we're on this journey together, we're learning, you know, what I just shared was kind of the information, the knowledge that we know. So once we've done kind of a needs assessment, if you could say, then we kind of move forward to what are those actions. We've asked, what is the problem? We know the problem. Now what are the solutions? And so one thing when we're looking at nutrition education material, again, there are great organizations that develop amazing curriculum and handouts and recipes that are evidence-based and wonderful to utilize. I think one thing to note is that oftentimes they're created for the general public, and so we work with a really amazing and unique population, individuals who are food insecure, and so they have unique challenges and barriers to what they're experiencing. And remember, any of you in David Just session just over on the other side of the wall? Okay, great. So Feeding America works really closely with David. I know he works a lot with the BT Fresh program here in Vermont. And so, you know, he's taken essentially these nudges or behavioral strategies that retails and school cafeterias have been utilizing, and he's kind of flipped them on their head and used them in the school pantry setting, pantry setting. And so we're kind of looking at doing that with nutrition education as well. And so the reason being, and I'll read this from here, is that we know that there's some key client considerations to take into effect. Again, we're not looking at the overall population when it comes to nutrition education, so what are we looking at? We know that individuals may move more frequently, that they may have disordered eating, that they may, and that's that yo-yo kind of effect, that they may frequently change phone numbers or lose phone service, that they may live without electricity periodically, may not have consistent form of transportation, they're at greater risk of smoking, may have less availability to exercise, and often may live day to day. So you all know these things, experience these things, talk to your community members and neighbors about these things. And so when we look at nutrition education, we all ask the question, well, what strategies and collaborations are going to be best for my community? And so that's a question for you all today as we move forward. And so there'll be a time at the end when I'd love for us all to share what's going on in our respective communities around this work. And so historically, nutrition education, again, has really looked, and this is in kind of the food pantry, food shelf, food bank setting, it's looked at as train-the-trainer, workshops and classes that could perhaps be over 6 weeks, 1 hour on Sunday evenings, or it could be an all-day Saturday workshop about diabetes management. And those are great, and they serve a purpose and can be very informative. We also know that there's point of service and nudges, and those last two are really what we've identified as niche nutrition education strategies for the settings that we work in. And the reason being is because they take into account those client considerations which we just shared, while at the same time they're a low lift and low cost for all of us that are working in that space. And I would just be kind of reiterating if I said, you know, oftentimes it's volunteers and limited time and whatnot, so those are really great that we'll talk about in detail here. And I'll start with a video. So those of you who were just in David's session, you will recognize him in this video.
Everything around us is forming these norms of what we should be doing. So walking through a grocery store, how does the choice to pick up a food present itself? It's what we see, it's what's the easiest thing to reach. It works with making it really visible and attractive and convenient. And people tend to respond to that. These subtle cues in the environment, the little things that push us one direction or another, we call those nudges.
One of the things we're really trying to understand here at Feeding America is how nudges can be used at both food banks and food pantries. And we reached out to David Just and his team at the Cornell School of Behavioral Economics to figure out how we might work with them to apply some of their theories in the school lunchroom and the retail environment and see how it might translate. The nudges strategies are often about just shifting the environment in a really subtle way. How these foods are displayed and what they're called.
It's stacking the deck so that the choice that is the healthiest is what's most likely to take place.
Nudges definitely help us to encourage and promote nutrition. Our warehouse is set up to mirror the Feeding America foods to encourage categories. We keep the most nutritious food in the beginning of where they're going to be shopping. So we hope that they'll fill up their shopping carts with the proteins and the grains and the fruits and vegetables. Since we arranged it this way, we've noticed that the agencies are certainly taking more of the healthier options.
As well, some of the simplest things that food pantries can do are try to move that produce so it's right up front, some of the first things you see. Taking a tasting station where you get an example of some of the foods that they can create, and all the things they need to make it, like recipes, they're just sitting right there and it's convenient.
Another example can be grouping food items together. This will make it real easy to see how to prepare a simple meal.
These nudges have a big impact on behavior, but at the same time, they're really, really inexpensive. The impact is going to show up not just in whether people are choosing this food or that food, but also in whether they make use of the food once they get home. When they decide, do I want this or not, they own their decision. And it's that that really creates the value.
Nudges also make sense from an operational perspective because we have a lot of perishable food in our network. These nudges not only encourage healthier choices on the front end, but on the back end help to distribute these items more quickly.
If you look at all the data out there, the families that are struggling the most with nutrition, they are lower income families. This is a way to directly impact those families for the better. I find that exciting.
So what we hope these nudges do in food banks and food pantries around the country is just to help to make these healthy choices the easy choices for agencies, volunteers, and ultimately for the people and the families that we're serving.
All right, so that was nudges. And can I get a show of hands again so I'm careful not to repeat too much? Who was in David's nudges session? Okay, great. So wonderful amount of folks. So this was kind of our quick snapshot. If we never have David to give a session, we show the video. But again, these are really great strategies to utilize in a food shelf setting. And the reason being is that minimal additional setup, if at all. So you saw in some of his research that you just put a fruit bowl and it helps increase the distribution of items. And low cost, high impact. It also helps increase foods to encourage, or healthful foods, just a Feeding America terminology, the distribution, and also a way to engage new partners. And so again, stepping back, for those of you who perhaps weren't in David's session, as the video showed, nudges are behavioral cues that help us change our decisions, and often unknowingly. And so it's kind of like when we're in the grocery store setting and we didn't have Get a Magazine on our grocery store list, but we get to the checkout counter and we're just standing there, and then we get home, we're like, why did I get gum and a magazine? Well, because that was specifically set up to kind of cue us to buy that. We also know that if you ever are in a cereal section in a grocery store, you'll notice all the kids' cereals are on the bottom two shelves, and often that reason is because kids, that's their eye level, and so they're like, hey parent, I want this cereal, and so it's like, okay, just grab it, let's go. So that's really smart marketing. And so we're not looking to, by any means, bribe folks at all, but how can we, again, make the healthy choice the easy choice by helping to nudge in one form or fashion. And so as you saw in the video, there's some really easy ways to do that. One is you can put the more healthful item at the beginning of the distribution line, or you can put it at multiple points in the line. So say you get, huge amount of pallets of apples. You're like, we got to get these apples out really quickly. One, you certainly want to help this contribute to the health of the individuals coming through. But in addition, you need to get the apples out. You don't want them to spoil. So you could get baskets and put them at multiple points in the distribution line, the apples that are available. And most likely you'll get someone that's going to pick up those apples, maybe not in the first basket, but later on they're like, oh, I'm seeing an apple again, I'll pick that up. We also know that if you put corresponding recipe cards near the foods to encourage, then individuals more likely to get that. And this is particularly the case. I know we get a lot of fruits and vegetables at times that, what is this? I don't even know what this is. How are we going to explain to someone else? So recipe cards are really great, and I'll point you in the direction of place to get recipes in just a second. And then also suggesting portion. So again, going back to apples, if we have a sign that says an average family of 4 takes X amount of apples, that helps. And again, this depends on what type of food shelf you are, but helps an individual know, oh, my family is 4 folks, I'm going to take 8 apples. whereas originally maybe only 2 or 3 would be taken, but you're giving them permission to take a certain amount. We also know, again, pairing foods to encourage to create a packaged meal. This is done all the time at the grocery store. It's a favorite of mine. If I'm running in, running out, I go to like, oh, tacos, all the ingredients for them are in one place. There's a recipe with it, I'm good going out the door. And then tasting sessions. I know those aren't always feasible in every location, but those are really helpful in helping someone try mango for the first time or any type of ingredient. Another kind of expansion on this idea of a nudge is point of service nutrition education. And so the one difference with this, again, still low cost in many ways, but that usually it's person-to-person interaction. So this is usually a 3 to 5 minute lesson while someone's in the distribution line. I know this could be the case with many of you all, as when I've gone to volunteer at pantries, I'll get there early to help set up, and I notice there's already a really long line of folks that are waiting to get in. So that's a prime opportunity to help provide nutrition education. So there's actually a pantry in Northern California, and they put on a little cart that rolls through like a science fair board, and they have cool activities. And they just roll it down, get a group of 5 folks, and I have a 3 to 5 minute nutrition education session on the actual ingredients that are going to be distributed that day. Keep moving down the line, give education again. It's a great way to involve kids and families, and then those kids are often primed like, hey parent, I want to get this when we go through the line today. So really empowering those children also to be part of the decision. And also cooking demonstrations. So this is different than a tasting, but rather you're really cooking with folks there, and you're providing messaging along in that process. So maybe learning how to sear something as well, or knife skills, kind of adding that into the mix. And then there's service integration. So this gets to your question earlier in that we know a lot of folks in our community have a diet-related disease. We know they're food insecure, they're coming to us for food, which again, most basic need. How can we partner to help address these diet-related diseases at the same time? And so a lot of pantries are working in collaboration with their local healthcare providers. There are many hospitals who are now providing pantries inside their hospitals themselves. They have the facilities, the storage, the refrigeration. We also know that a lot of food pantries or food shelves are actually providing health screenings. So folks are going to come for the food. They're not always going to go to their healthcare provider even if they're not feeling good, for lots of reasons that we all know. So it's great to be able to provide that health screening at the food shelf and then making the connection to the local healthcare provider. And then there's a partnership between the Interfaith Food Shuttle and a medical center in North Carolina where the physicians provide essentially produce as the prescription. So it's actually a prescription notepad that looks like a prescription, and it just there's a few different options kind of veering off from this. It may say go to your local farmer's market, where I'm not sure here in Vermont, do y'all do double your bucks? Yes. Okay, great. So like I was on SNAP, and it was great because when I would go to the farmer's market, I could get double my bucks. I might have $10 left in SNAP benefits, but I would get $20 worth of produce, which was really wonderful. And so that's something that physicians are doing more often. And it could also look like a voucher to go to their local food pantry as well. So helping to identify that one of their patients is food insecure.
A lot of these use it that way. But,
and I want to kind of stop talking at you all, so I'll just run through these last really quickly. So just, Feeding America from a national perspective, we're trying to get at what are the evidence-based interventions around diet-related disease, nutrition, and food insecurity. And so just we're doing some work around in the space of diabetes. We did a 3-year pilot study, which was really great. In addition to knowing that hemoglobin A1C levels kind of were at a steady space, we also found that levels of depression went down for those who participated. So this is really great. And from that, we're now doing a randomized control trial, so essentially the gold standard of research, to really evaluate and quantify kind of the impact of this intervention. And the community benefit, I'll just note, so for those of you who maybe are working with healthcare partners, may know that with the Patient Protection and Affordable Care Act, there's a provision in there that says for nonprofit hospitals to maintain their 501c3 status, they must participate in a community needs assessment and then develop a CHIP, essentially a community health improvement plan. So this is a great opportunity for food banks or food shelves to also insert ourselves and say, food insecurity needs to be part of these conversations. It needs to be part of the needs assessment, and it should be part of the improvement plan. So we're actually doing a pilot right now in Alabama with their local food pantries. And so this is just a picture of Redwood Empire Food Bank in Northern California. They're doing the diabetes pilot here. And so again, I shared a little bit about what we had learned. Again, we know that food is medicine. Clients are interested in health screenings and education at the distribution site, at your food shelves. We also know that clients with type 2 diabetes who visited the food pantries, again, we know they want to receive healthy foods. Health clinics are really enthusiastic about work because, frankly, they're having a tough time getting this demographic that we work with into their doors. And so they're like, you're inviting me to your food shop? I'll be there. And that's a great way for them to help their numbers. And ultimately, obviously, serve our community health. And it just requires some creativity sometimes, kind of thinking out of our box. And so the last thing I'll note is that healthyfoodbankhub.org, again, shared that website a few times now, but what it was developed because we were hearing from food banks saying, you know what, we're also hearing from our food shelves and food pantries that when it comes to finding healthy recipes, I'm getting them offline, but a lot of times they may have lots of equipment that's utilized, they take a long time. I just want to be able to search, again, we got pallets of asparagus, and I just want to find a recipe with asparagus that doesn't have a lot of ingredients. Where do I go? So one of the kind of developments of the Healthy Food Bank Hub was around this, and it's the tools and resource section. But in addition, it was really developed to help bridge this conversation with hunger relief professionals, health professionals, and nutrition professionals to talk about food insecurity, nutrition, and health. And so it's really an educational site in some form and fashion. But the tools and resource section has over 400 assets. This includes healthy recipes, nutrition education materials, etc. And they've all been vetted. So there's a criteria for each of these types of resources, and they've all been vetted to meet the unique needs and challenges of food insecure individuals. And again, you can search by ingredient, you can search by no heat recipes, so there's lots of different options that I'd encourage you to check it out. And then how many have a food shelf website or blog? There are a few, so one, maybe a few here. Okay, so I don't know, are they for your community members? Do they go to your websites, or we don't know? Okay. Well, you can start encouraging. So this is really an asset that hopefully it's really easy to load. You simply go to the hub, and this is called, we're calling it a widget, but you essentially would copy and paste this onto your website via code, and Feeding America can help out with this. But it provides an option. There's 9 different sizes and designs. Over 24 organizations already have it on their website. And it allows essentially our neighbors who are food insecure to have direct access to items on the Healthy Food Bank Hub. So direct access to nutrition education materials or to recipes. So it's, again, an easy one-stop shop as opposed to having to search all over the web. They know that these are specific to their needs. So for the rest of the session, I'd just love to hear from everyone regarding kind of where you are in your space. I'm available to answer questions. I know we're also at the end of the day. It's a beautiful day to enjoy. But so I'd just love for us to kind of get a gauge of what your needs are in your community, what you're doing around this intersection of food insecurity nutrition space. I know we got a great example earlier as well, but would anybody be willing to be our first volunteer sharing? Sure.
I'll share one. I'm Scott Winslow. I'm the coordinator at the Kitchen Cupboard in Bennington Food Distribution Program. This is not something we're doing, but it is a goal that we hope to be doing soon. The board of the agency that administers the Kitchen Cupboard Food Program also runs a free medical clinic. And they're both relatively new, and the board's goal is to co-locate them. And they've been working on that for a couple of years, and it's not happening yet because it's hard to find a space that we can use and have access to. But everybody's talking about, we know there's a connection between health and nutrition. We want to put them side by side. So I hope that comes true in the next, the near future.
Yeah, and I think this speaks to, a lot of these things take a long time, and that's going to be a great kind of result that you all have is kind of this side-by-side partnership. And sometimes it may look that elaborate, if we can call that one elaborate, and then other times it might be really simple. But all are great. It's one step at a time as we work through this. And so it's great to see that. That's probably has taken, again, as you said, a lot of years, conversations, and a few people might have sparked the idea, but that ball has continued rolling over time. So definitely. Saw someone with their hand earlier. Well, yeah.
A question that I didn't get a chance to ask.
Oh, sure, David?
Yeah.
I will try to
did
be
ask
as
him
smart as you, but
afterwards.
yeah.
I did ask him afterwards, and he didn't actually have an answer. He said we need to study this. So I wondered, the people in this room certainly have experience with this type of problem, and that is hoarding, where people are taking more than their fair share. Households of 2 are taking enough to feed a household of 10, and it can cause tremendous problems at food shelves or even within the client base. People are looking saying, I know you're not going to eat all that food, you're wasting that.
Yeah.
So you talk about behavioral nudges.
Yes.
What might you suggest?
I would be curious to ask David, because what first comes to mind for me is the sign that's, and I know he said he didn't know, but I would try and jog his memory on this one thing that he shared with me in the past. Is remember what I was saying, we kind of give context to individuals as they're coming through the line that, oh, a family of 4 usually takes X amount of apples.
Yeah, I saw that.
So in some ways we're talking about that prompting someone to take more, but it could also have the reverse effect. I'm just saying that, I have no idea. But that would be something that I would be curious to ask David to see if that helps jog his memory, or at least what his, you know. Oh, you can answer? Awesome.
My name is Ron, our place spells false. I distribute food in the pantry, and I know what it's like when somebody takes more. Is that what you're getting at? Yeah. Usually what I do in my case is I let them know that last time they kind of overdid it, and so I short it out right there. I make sure they go home with something. So I tell them, go around, take 2 of everything this time, because last time you really overdid it, and we know you did, and we don't want to not serve you. We want to help you. And usually the embarrassment factor goes down to an even level, and you get around a little more. And now we have a couple of people that actually did that come back and help us here and there. Blunt force trauma mentally is basically what you got to do. You got to stand up for what we all serve for.
Yeah, so there's different strategies to kind of what your philosophy at your food shelf is, and so yeah, it's interesting. You know, that's the tactic or utilization that you use, and I've heard that being used in others. So, but from a behavioral economics perspective, it would be interesting to know again if that sign might prompt one way or the other. So, but again, I'm not sure. You have the evidence behind what you were talking about for your experience, so I'm not sure.
I do. I mean, I have a few people that actually come back and shame is a very powerful emotion. They feel ashamed and they come back, hey, can I help you? So I'm like, you're okay, man. If you want help with something with the truck or whatever, and then it balances out. We see each other in the community, and we know sometimes there's some good stuff that you really want to have some, and then you stick around long enough and you just become part of it. It works.
So yeah, I think ultimately we want to kind of help individuals get what they need. So, again, it might be different. So I saw lots of hands pop up. I'll start from the right. There was one. Yeah.
Yeah, I just wanted to respond to that question.
Sure.
Because this is something that comes up, unfortunately, I think for all of us. And one of the things I've noted in our food shelf is that frequently when we are dealing with hoarders, they tend to be families where we're in a very, very rural, small area. It's generational poverty that we're dealing with. It'll end up being people who've grown up in food insecurity, who now have children, who are adults, who have food insecurity, and it's you can't judge. The only thing you can do is just love them, and to try to find a way to talk to them quietly and gently, and address the issue, as in as personal a way as possible. I don't have any golden bullet, except to just, hold their hand and tell them that, maybe 4 boxes of cereal is more than you need for your 2-person house.
No, I appreciate you sharing that.
But
Yeah,
it's hard.
We do know, over time, talking about generational poverty, it's a psychological, kind of process that your body goes through, and then you're feeling that. So I appreciate you bringing that to light. Yeah. Right here, and sorry, let me start over here.
A while back, someone from a food shelf, and I don't remember where it was describing the same problem that this lady was talking about. And what she did was privately talk to the person, because a lot of times there's something going on with that person, that maybe they're a family of 4, but maybe for a month they're a family of 12, and you don't know that. So just talking to them and seeing if there's another way that you can help makes them appreciative, and next time they actually didn't take as much. So they maybe had this panicky feeling to take more because it was free, and then when they realized that someone listened to them and understood and sympathized with them, they were like, oh, it's okay, because if I do need more, I can just ask.
Yeah. Exactly. Knowing each other's stories, right? We're all neighbors, and so it's absolutely.
So I was going to direct us some things that we're doing in our community. First, to respond to that question, I work out of a domestic and sexual violence organization, and one of the things I found, and I know a lot of folks that we work with do utilize the food shelf, and one of the things that I've noticed coming from that perspective is that generally when I've had people do the same thing at shelter, is that it's one thing that they never had control over, and now they do. And so, one, they might not know how to pick their food and how to utilize that. So, I've had to offer some guidance, and it was always an offer. They didn't want to take it from their family. But then, also, that it's something they never had control over, so now that they do, they are probably just naturally going to do it. So that's coming from that side. And then what we're doing is we just opened up within shelter a wellness room so that they can get activity and utilize the positive aspects to decrease their stress. And we also started a program where we meet, I generally run a group where we do cooking classes and show them how they can utilize the stuff that I ordered from Foodbank in order to have good nutrition and be able to feed their family and take what there is and not make a meal for 10 when they have 2 or 3. So that's something that we're doing, and we're hoping that now that we have our community center open, that we can branch that into the community a little bit more. So.
And how empowering for individuals in that point of life transition.
Yeah.
Great, Jamie.
I'm Janet Michaels from Bennington at this pantry. And we've kind of solved that problem, I think. We have 4 different sheets that people can fill in. And it says if you are a family of 2, you can get a jar of peanut butter, et cetera, all the way down. Fruits and vegetables, they have people there that are helping them. And then there will be someone that will go with them and then help them fill this up. So they decide they can have a box or 2 of cereal depending on how many there are in the family. And it all still goes by each individual person, because one person may say, 2 of my 20-year-olds just came home for the month, hopefully no longer. And so they will, give them extra because of that. So the clients still have a say, and then they choose the kind of cereals they want. They choose whether they can get 2 or 3 vegetables. They choose the kind of vegetables they want, but they get what a family of 2 would get. A family of 4 gets more. A family of 6 gets more, and over that, then they get the bigger, pieces of meat and all these things like this because they have a bigger family. And that has really made a difference because we have enough to serve everybody that comes at the last minute.
Yeah.
We've still got stuff for them, and we're not telling anybody that they eat too much because they know what their limit is.
Yeah. And that's really popular, at least from what I've heard from others around the country.
And it's worked very, very well.
Great, thank you all for sharing. So I'll start with you, and then we'll go. I know you've had your hand up, so whichever.
So I know someone over here was interested in doing behavioral economics sort of thing. Well, with that, that's very close to what a lot of businesses do to avoid shoplifting. They'll have someone actually go and either follow or consistently ask someone if they need help. And if you do that in a hoarding situation, just have a volunteer or someone ask them, do you need help, do you need this? They'll monitor themselves because now they're realizing that someone's watching what they're taking. And it's not a great situation. I've been on the opposite end of it. It's not fun. But if your real issue is trying to reduce the hoarding, that's a pretty good and effective method.
Yeah, I think there's a lot of, we've talked about, we always ultimately want to be respectful of the community members and neighbors that we're serving. And so I think there's some more systematic ways that apply to every individual that comes through the door. And so personally I see, and it's, effective, is that when we standardize it across the board, I think that's the most respectful. And then we may have individual conversations or knowing someone's story, and that of course adds to, these are our neighbors that we're serving. So yeah, thank you all for sharing. Great.
What we've done in our food shelf, I'm from Pittsburgh, and we have shopping lists based on the same as what you've got, based on the number in your family. And then when people come in, we'll say, hey, do you want someone to go around with you today? So that way we get to know them a little bit more of what's going on in their life. If they've got a crisis going on or something, we can throw in a few more things. And it makes them feel like, they're very welcome.
And that's an option, right? That they get to choose to have someone who's
Yep, they do. And if we start seeing that people are taking a little bit too much, when they go around to check out, we may, just say, oh, you know what, on your shopping list here it says, you're supposed to take five cans. Here you've got 10. Let's go ahead and put a few back because there are other people that need to come in. And it's like, oh, I'm sorry. And we said, well, just remember next time because there are other people. And it works out. And for those people, that end up taking a lot, we'll say, you know what, this month we're giving everybody personal shopping assistance. So we'll go around with you, and if you've got any questions or have any special needs, let us know and we'll take care of it. And that takes care of our problems.
It's also good with our list, if we get in things that aren't normally on the list, we can let them know that they can have these other things that are extras that we don't normally get.
Yep.
It works very good.
On that, pertaining to the list, we call it our miscellaneous shelf.
Okay.
And based on their size of their family, we'll say how many items they can take off that miscellaneous shelf. So, when they're getting ready to go, it's like, oh, did you go to our miscellaneous shelf? Take what you need, take your items, and I'll look forward to that.
So I know we have just a few more minutes left, so I just wanted to kind of get back to where we kind of began the circle today around the intersection of food insecurity, nutrition, and health. And, I think one thing, there's a video that we showed in the initial session this morning, and it was about this intersection that we've talked about here, and it's animated. So it's a great opportunity to share with your other staff at the pantry, your food shelf when you go back. Sorry, I keep saying pantry, that's kind of what we say from the research perspective. So, but the food shelves here in Vermont, go back to share with your staff. But I just encourage, as we're thinking about, again, these challenges that we all experience in meeting our basic needs, the additional steps and opportunities we have to make a difference for our local neighbors that we're serving. So thank you all, and if you have any questions, I'll be up here as well.